المحاضرة شوية طويلة، بس المعلومات اللي فيها حاولت أبسط لكم هي على قد ما أقدر، لأنه عارف إنه الكونترسبشن دائما موضوع طويل وممل في المذاكرة، فإن شاء الله تعجبكم يعني. So we're going to outline the contraception failure rate, the continuous OCPs, the patch, the ring, Depo Provera, the IUD. We're going to talk about emergency contraception, postpartum contraception, then the leftover contraception. Also, we're going to talk about missed contraception and what to do. This is the generation of the progesterone. We have 4 generations, the first and second and third and fourth generation. In the first generation, you can see the group. It's the norethindrone acetate, ethinyl nadiol. وفي second generation levonorgestrel والnorgestrel. Third generation aldesogestrel and the norgestamine. And in the fourth generation, we have the dosperidone. Each contraception will have an amount of the progesterone and an amount of the estrogen. In the coming slide, we're going to discuss some of the generation and in what pills they're found. So what goes with what? The norethindrone, you can find it in the monophasic, biphasic, and the triphasic. In the previous lecture that I gave to the other residents, some people had questions about what's the difference between the monophasic, biphasic, and the triphasic pills. So it all depends on the amount of progesterone to estrogen in the pill. Okay, so في المونوphasic حيكون the amount of estrogen to progesterone is steady in the entire package. In the biphasic, you're gonna find that the concentration will differ at the beginning of the cycle and at the end of the cycle, and the triphasic the same. At the beginning and then in the middle of the cycle and then at the end of the cycle, the concentration will be different. The norethindrone acetate is found in the triphasic pills. Levonorgestrel is found in the Alice or Portio, وهو نفسه الهرمون اللي موجود في الميرينا والإمبلانون. Norgestrel is found in the overall pill. Degestrel is found in the Apri. The norgestamine is found in the ortho, and dosperidone is found in the Yaz pills. طبعا the progestin part, there's a lot of advantages and disadvantages of the progesterone. It depends on how strong the progesterone is to give you unwanted side effects or disadvantages of each one. يعني مثلا some of the pills, you're going to find that when the patient is on it, she'll have spotting. Some of them will have decreased libido. Some of them will have more androgenic effects. زي الياز والديان, they have more androgenic effects. So you're going to find that people with PCOS or people that have high androgen or hirsutism, they're better to go with those kinds of pills. Contraception failure rate, طبعا when it happens, that's the OBSI babies. طبعا oops, somebody's pregnant. Why are they pregnant? So we're going to find out why some people that are on the pill or on any method of contraception get pregnant. So there's something called the Pearl Index, and the Pearl Index is the number of pregnancies per 100 women in 1 year. And it's calculated with this formula. You need to memorize the formula because sometimes it's an MCQ question in the exam. Contraception failure rate, so you're going to find that in the Mirena, Depo, and copper IUD, the failure rate is about less than 1%. In the continuous pill or progesterone ring and patch, it's about 8%. Male condoms and diaphragm, it's 16%. Sponges, cervical cap, female condoms, or rhythm or withdrawal, or spermicides, it's about 20 to 30%. Vasectomies, it's about 0.15%. Tubal ligation, it's about 0.5%. If you're using none of the contraception, then failure rate or pregnancy rate is about 85%. Okay, just we're going to talk a little bit about the rhythm and the withdrawal. So rhythm اللي هو بالعربي الناس اللي يستخدموا الجدول okay أو العد. So no intercourse happens at the time of ovulation. So on day 14, you take 2 days before and 2 days after. Withdrawal method, people that don't use any method of contraception, and the ejaculation happens outside the vagina. So tubal ligation 10-year failure rate. So this is the types of tubal ligations that we do and the failure rate of each type. So with the unipolar tubal coagulation, it's about 0.8%. Postpartum partial salpingectomy, it's about 0.8%. Silicone ring, it's 1.8%. Interval partial salpingectomy, it's about 2%. Bipolar coagulation, it's about 2.5%. And with the Hulka spring clip, it's about 3.7%. So the highest is with the Hulka clip. And the least is with اللي هو unipolar coagulation and the postpartum salpingectomies. So you can memorize it as up, rip, C. Okay, so up it goes with اللي هو unipolar and postpartum, they account for 1%. الرب اللي هو silicone ring, الانterval partial salpingectomy, bipolar, it's about 2%. A C with the Hulka spring clip, it's about 4%. So this is an exam question. What's the contraception failure rate? So what's the Pearl index rate? So pregnancy per 100 women in the first year of use. These are some MCQs on the contraception, and I just want you guys to know how to answer these questions. طيب لأنه الquestion هذه sometimes it's a little bit confusing. طيب. So when they ask you what has the lowest maternal mortality rate and what has the highest maternal mortality rate, okay? So the lowest maternal mortality rate is associated with the OCPs because the failure rate حقت ال OCPs, it's about 8%, so it's very low, okay? What has the highest maternal mortality rate? طبعا اللي هو الرhythm method، يعني إنه لو واحدة بتستخدم which mode of contraception will be associated with high risk of getting pregnant. So هذا معنى السؤال هذا. Okay, so the lowest pregnancy rate will be with the OCP and the highest pregnancy rate will be with the rhythm method. Contraception failure rate, برضو هذا past question. What method has the higher failure rate for sterilization at 1 year? اللي هو قلنا الكليب, it's about 4%. So now we're going to talk about the pills and friends. So we're going to talk about the combined pills, the patch, and the ring. So for the contraindication, all of you guys need to know what are the absolute contraindication and what are the relative contraindications. So for absolute, we have, if you take it from head to toe, we're from head, طبعا ال CVA history, migraine with aura, ischemic heart disease, complicated valvular disease, pulmonary hypertension, atrial fibrillation. If somebody has an uncontrolled hypertension, liver cirrhosis, liver tumors such as adenomas or hepatomas. VTE, if somebody has a current or past history of VTE, severe thrombophilia, if the woman is less than 42 days postpartum with VTE risk factors or less than 21 days postpartum, you can't start them on continuous pills. Others, اللي هي لو she's older than 35 years old and smokes more than 15 cigarettes per day, diabetes with end organ damage, or current breast cancer. So these are absolute contraindications. You shouldn't be prescribing combined contraception for those women. Relative contraindications, لو كان واحدة more than 35 has a migraine without aura, عندها controlled hypertension, mild cirrhosis or OCP related cholestasis, symptomatic gallbladder disease, لو عندها history of SLE, لو she's older than 35 and smokes less than 15 cigarettes per day, هدول بيكونوا relative contraindications. بعد كده عندنا some medications that interfere with OCP metabolism. So you have the antifungal, you have the HIV medications, anticonvulsants, TB medications, and you can memorize them بالكلمة دي اللي حطيت لكم هي اللي هي funky hats. Okay, increase the OCP failure. F goes with antifungal, HATS اللي هو ال HIV, A anticonvulsant, T TB, S اللي هو ال St. John's wort. So they increase اللي هو ال OCP failure rate. So less than 5% failure are from the drugs interaction that are listed in this slide. The patch ring relative contraindications, but we will add this to a relative contraindications الثانية. في الباتش بيكون عندي اللي هو if a woman's weight more than 90 kilos, it will decrease, it will has decreased efficacy. في الرينج لو واحدة عندها prolapse or vaginal stenosis, this could prevent us from using اللي هو النوفا ring. For combined birth control, طبعاً we have non-contraceptive benefits. So hormonal benefits, you can treat acne, hirsutism, premenstrual symptoms. Even you can treat perimenopausal symptoms. It regulates the cycle, decreases the flow, or decreases the amount of dysmenorrhea that some patients will experience with their periods. Genital tract, it can treat fibroids, it can prevent salpingitis. It has somewhat a role in ovarian cyst, decrease the formation of ovarian cyst. Cancer, it decreases the risk of endometrial cancer, ovarian cancer, and there's some studies that support the decrease in colorectal cancer. It increases the bone mineral density, and it can increase اللي هو benign breast disease. OCPs and cancer, so it's good for ovarian cancer, endometrial cancer, and colorectal cancer. So in ovarian cancer, less than 10% with 1 year of use and less than 50% after 5 years. What does this mean? يعني لو عندنا patient is using a combined pill, in the first year, she's decreasing her risk of ovarian cancer by 10%. After 5 years of use, she's decreasing her risk by 50%. The effect lasts for 10 to 20 years after اللي هو the last use of the combined pill. Endometrial cancer, in the first year of use, you're decreasing the risk of 50%. In colorectal cancer, with 8 years, we found that it decreases the risk by 40%. And this was in the Nurse Health study that all of you guys should read, because it's about the previous cancers and the association with hormonal treatment. So decreased by 20% with ever users in a meta-analysis. May be bad for some cancers. So for breast cancer, 3 in 1,000 from 2 in 1,000 cumulative incidence up to 35 years of age. Maybe because women that were included in this study, they delayed having the first child. So that could be the risk why they had breast cancer. Cervical cancer, it increased by 2 times invasive cervical cancer after 10 years. Mixed results طبعا because of the difficulty of controlling for confounders, HPV, condom use, and smoking. For liver cancer, there's weak evidence that it increases hepatocellular carcinoma. So what about VTE and MI and stroke? So with contraceptive combined methods, if you're less than 35 years, your risk of VTE is 1%, okay? Well, MI 0.1, well, stroke 1%. If you're less than 35 وبتستخدمي combined pills, then your risk of VTE is 3%, MI is 0.2%, and the stroke is 1%. If you're pregnant, this will increases your chances of having a VTE to 30%, or sorry, 30 times increased your risk of having a VTE. And if you're immediate postpartum, then 300 times risk of getting a VTE in the postpartum period. So always remember pills and VTE, the rule of three, so 3, 30, and 300. So what do we do with missed combined methods؟ طيب إذا كان المissing في اللي هو less than 24 hours, because with the patch and with the ring what happens طبعا في ال OCP woman will forget to take a pill, لكن في الباتش طبعا احنا كل اسبوع we have to take the patch and put another one. So sometimes if you delay اللي هو taking off the old patch and putting on the new patch less than 24 hours, ولا الring, some people will take the ring out during intercourse. So if it's out less than 3 hours, so use ASAP and continue the cycle. So if the pill, you can take 2 pills in one day. If the patch, then you're going to take the old patch and put a new patch on. What ring, if you remembered in less than 3 hours, you're just going to insert the same ring back. Okay. If the delay was in the first week of use, so if you forgot 1 pill, if the patch was more than 24-hour off, or if the ring was more than 3 hours out, okay? So a delay is more than 24 hours. So what we do, we use it ASAP, continue the cycle. You have to use backup for 7 days, and emergency contraception if sex happened in less than 5 days. في second and third week of اللي هو الuse حق الpill والpatch والring. So if you have missed less than 3 pills, if the patch was off for less than 72 hours, but ring was out for less than 72 hours, so you have to use them ASAP, continue the cycle, skip the free interval and start a next cycle with no backup or emergency contraception. If they were out for more than 72 hours and you missed 3 pills, then use it ASAP, continue the cycle, skip the free interval and start the next cycle with backup for 7 days and emergency contraception if sex happened in less than 5 days. Okay? Any questions about the missed contraception, the combined? Okay, so we will continue. بالنسبة للي هو البروجسترون only والديبو shot, okay? So if you're using progesterone only pills and you forgot to take it less than 3 hours, you're gonna take it as soon as possible and then you're gonna continue the cycle. If you forgot to take it and it's more than 3 hours delay or you missed the pill, okay, then you have to use it ASAP, continue the cycle, back up for 2 days, and emergency contraception if sex happened in less than 5 days. هذا بالنسبة للprogesterone only pills. لو واحدة بتستخدم اللي هي الديبو بروفيرا، okay, طبعا الديبو بروفيرا we use it every 12 weeks. So if less than 13 weeks, so and 6 days since the last shot, you're gonna use it ASAP. يعني أول ما تفتكر حتاخدها. لو كانت delay more than 14 weeks, you're gonna check a beta HCG. If the beta HCG is negative, then you're gonna use the shot. So you're gonna take the shot على طول with backup for 7 days and emergency contraception if sex happened less than 5 days, and you have to repeat the beta HCG in 3 weeks. So questions about the combined pills. Which of the following is a contraindication to OCP? And you have to list 4 relative contraindications to birth control pills. 2 malignancies that incidence is increased with OCPs, and 2 malignancies that incidence is reduced with OCPs. Excuse me. Two malignancies increased اللي هو في السلايد هذه I listed اللي هو الانسرز لل cancer that are increased and the cancers that are reduced. And then this question is, if you miss 2 OCP's doses in the 3rd week, what to do? Name 3 medications that decrease the efficacy of OCPs. So if you missed in the 3rd week, this is what you're going to do. And these are the medications that decrease the efficacy. Funky hat. Always remember, funky hat. So now we're going to talk about the Depo-Provera, the shots. What are the indications, contraindications? What are the benefits? And we're going to touch bases on the bone mineral density. So the indications, if the woman has any contraindication to estrogen, if she's breastfeeding, it's good for endometriosis, for premenstrual symptoms, for sickle cell disease, especially that there's studies that showed that it might decrease the crisis. If any patient is on anticonvulsant for seizures disorders, it decreases the seizures incident and decreases the efficacy of combined. Contraindications, absolute if the woman is pregnant or if she's known pregnant or suspected, unexplained vaginal bleeding, you have to rule out cancer in this scenario. And if a woman has current breast cancer. Relative, so severe cirrhosis, active viral hepatitis, benign hepatic adenoma, prior history of breast cancer. So for patients with breast cancer, if they want contraception, the first line option is the non-hormonal. Contraindications, so we have the absolute زي ما قلنا اللي هو unexplained vaginal bleeding, current breast cancer, a relative, migraine with aura, uncontrolled hypertension, vascular disease, history of ischemic heart disease, hepatocellular adenoma, VTEs, SLE with antiphospholipid or severe thrombocytopenia, past breast history, diabetes with end organ damage. What are the Depo benefits? So it can cause amenorrhea, so decrease dysmenorrhea and decrease anemia, decreases endometrial cancer, decreases the risk of PID. Some studies showed that when there's thickening in the cervical mucus, this could lead to decreased PID incidence, decrease the symptoms of endometriosis, decrease the crisis of sickle cell disease, وزي ما قلنا إنه decreases the incidence of seizures. So طبعا دائما issue with the Depo-Provera, people are afraid of the bone mineral density. Okay, so it decreases the decrease in the bone mineral density is transient. There's no difference in the bone mineral density after stopping the Depo. Routine bone mineral density testing is not recommended. The greatest بيكون in the new users in the first 2 years. About 1 to 3.5% will have decreased bone mineral density. 6 months of breastfeeding, الريسك بيكون 4 to 5%. Okay, so breastfeeding can cause decrease in the bone mineral density more than the Depo shot. Special caution بيكون في الادوليسنت والبيريمينوبازل، لانه الادوليسنت البونز حقتهم لسه بتتكون، وفي البيريمينوبازل بيكونوا already they're lacking calcium and they're lacking estrogen and vitamin D. So counseling should be done in those 2 age groups, and you should emphasize on the patient to take calcium, vitamin D, to do weight-bearing exercise, decrease caffeine and alcohol, and smoking. So past questions on the Depo, list 4 non-contraceptive benefits of the Depo, or 4 contraindications to Depo-Provera. هذه اللي هي الانسرز. Now we're going to talk about the IUCD, so the coil. What is the efficacy? What's the contraindications, benefits, side effects? We're going to talk a little bit about the insertion, perforation, and expulsion rate. If there's a missing string and the patient is pregnant, what should we do? And we're going to talk about STIs and actinomycosis related to the IUD. So the IUD efficacy, pregnancy rate with the copper IUD is about 1%. With the Mirena, it's about 0.1%. Ectopic rate with the copper is 0.2, and with the Mirena, it's lower, it's 0.02%. Mirena pregnancy rate equals the copper IUD in 10 women. This is what Spiroff quotes. The mechanism of action, both of them will cause a sterile inflammation of the endometrium. Copper decreases sperm motility. Levonorgestrel thickens the cervical mucus, endometrial desexualization, glandular atrophy. It affects the receptivity of the endometrium, so receptors are suppressed, and there's suppression of ovulation. Absolute contraindications طبعا إذا واحدة عندها infection, PID or sexually transmitted infection, current or recurrent in the last 3 months. إذا واحدة كان عندها puerperal or post-abortion sepsis, cervical cancer or endometrial cancer, trophoblastic neoplasms, breast cancer, especially for اللي هو the levonorgestrel IUD. Others طبعا pregnancy, very distorted endometrial cavity, unexplained vaginal bleeding, copper allergy for اللي هو الcopper IUD. Relative contraindication, low increased risk for STIs or HIV, decreased immunity such as HIV patients or corticosteroid treatment, gestational trophoblastic disease, ovarian cancer. Others اللي هي لو الwoman كانت 48 hours to 4 weeks postpartum. Okay, it's a relative contraindication because it could be expelled. البنفيتس and side effects، معلش سوري على الالوان حقت السلايد، ما اعرف ليش طلعت كده yellow and green. It kind of hurts the eye، بس ان شاء الله الانفورميشن حتكون واضحه. الكبر 65% have increased PV bleeding. 10% of patients will remove it in the first year, and 20% will remove it after 5 years. Okay, in the levonorgestrel IUD, 85% have decreased flow, including fibroid related. 25% will have amenorrhea. There's decrease in the amount of dysmenorrhea. Endometrial hyperplasia could be prevented even when patient is on tamoxifen. Both of the IUDs will decrease the endometrial cancer, pain, or dysmenorrhea, small PID risk in the first month, and expulsion rate is high. 30% will have functional ovarian cyst, and some will have hormonal side effects. So هذا question is an exam question, how to insert an IUD. So during or just after menses, why do we usually use this timing? Of course, pregnancy is ruled out. Masks the insertion related bleeding. The cervical canal will be more opened, may slightly increase the risk of infection, expulsion rate, removal rate for pain. Is there a role of antibiotics? You're going to find that some guidelines don't recommend using antibiotics, and some will recommend using antibiotics a day before the insertion and on the day of the insertion. For the exam purpose, what the books quote that no need for antibiotics prior to insertion of IUD. If there's any mucopurulent discharge or pelvic tenderness, swab the cervix, treat, and then delay the insertion of the IUD. No good evidence for routine screening or antibiotics prophylaxis. IUD perforation, so 1 in 1,000 risk of perforation. Risk factors, طبعا postpartum insertion, unexperienced operator, immobile uterus. So if somebody has endometriosis or a large fibroid, very anteverted or retroverted uterus, هدول كلهم will increase the risk of perforation. Decrease the risk of perforation. Avoid طبعا postpartum. الoperator لازم يكون experienced in inserting the IUD by manual examination, tenaculum to straighten اللي هو the cervical canal, and sound the uterus. IUD expulsion rate, so 5% expulsion rate in 5 years, most commonly in the first year of use, so it's about 2 to 10% in the first year. Risk factors, طبعا لو واحدة كان عندها prior expulsion, so her risk of having another one is going to be 30%. لو حطيت لي واحدة immediate postpartum or nulliparity. So what do we do if the string is missing or if the patient is pregnant? So if the string is missing, أول شيء we're going to do a beta HCG to rule out pregnancy. If she's not pregnant, then you can explore the cervical canal for string. Ultrasound could be performed to identify if it's in the uterus or not. If found in the uterus, you can leave it in. If it's not found, then you have to do an abdominal x-ray to see where it's located, okay? If it's outside the uterus, طبعا you're gonna book the patient for laparoscopy and removal of اللي هو the IUCD. If the patient is pregnant, then CRAP, you need to do an ultrasound to rule out ectopic pregnancy. If doesn't want the pregnancy, you can leave the IUD in until اللي هو a therapeutic abortion is done. طبعا هذا accordingly the guidelines لأنه they're doing therapeutic abortions, but here for us we usually don't do it because of our religion. So if doesn't want the pregnancy, actually there's nothing that you can do. If she wants the pregnancy, then if the string is seen, you can do gentle traction on the string. There's no risk of spontaneous abortion, and string not seen, then you can do gentle exploration of the cervical canal. The string is lost, leave it in until delivery. If the string is lost, then you leave it in until delivery, but you need to counsel the patient about ruling out اللي هو perforation with an ultrasound just to see if it's inside or out. There's no increased risk of infection if you leave it in, no increased risk of congenital abnormalities. There's 4 times risk increase of preterm labor and preterm birth, okay? The other thing that I wanted to say, if the string is not seen, okay, and you're going to do gentle exploration of the cervical canal, so there is increased risk of spontaneous abortion. It's about 25 to 30%, okay? But is a string seen and you just pull it out, there's no increased risk of spontaneous abortion. So what about IUCDs and sexually transmitted infection and PID? So chlamydia or gonorrhea cervicitis, you can leave the IUD in and then treat as usual. For PID, remove after pre-treatment with 2 doses of Canadian STI guidelines or ECOG. The STI's guidelines, they're all the same about what antibiotics to use for PID. So لو واحدة جاتك عندها PID, you remove after pre-treating. لو واحدة عندها chlamydia and gonorrhea, you can leave it in and just treat as usual with the antibiotics that we usually use. For actinomycosis, it's a commensal vaginal organism that can cause frank infection, grows in clusters of gram-positive branching filaments with PMNs, presents on cervical smear, asymptomatic, you can leave the IUD in, you can do yearly PAP and bimanual, counsel regarding PID signs and symptoms, and you can offer antibiotics. هذه لو المريضة asymptomatic. طيب. لو المريضة symptomatic, you have to treat her with penicillin or tetracycline or doxycycline. طيب, والtreatment, it's a little bit prolonged. It has to be from 1 month to 6 months. طيب, وبعد كده remove ال IUD after antibiotics. If the patient has severe infection, you have to consult ID and she has to receive IV antibiotics for about 2 to 6 weeks, and then you can switch her to oral antibiotics for 6 to 12 months. So actinomycosis is not fun. So past questions on IUD, list 4 non-contraceptive benefits of Mirena IUD. Beside contraception, what are 2 other indications for IUDs? So those are the benefits, and it's the same. The second question is the same answer, but it's السؤال بصياغة تانية. When considering a copper IUD, which is true, failure rate in the first year is about 3 to 5%. Only 80% will continue to use after the first year. It can cause an intense contained infection within the endometrium to prevent implantation. So the correct answer that 80% will continue to use after 1 year. Then there's some MCQs on an IUD. So patient is asymptomatic with an IUD that has been in for 3 years. Pap smear shows actinomycosis. What is the management? And actinomycosis, what do you see on gram stain, and how long would you treat? So هذه اللي هي الإجابتين على السؤالين دول. List 3 reasons to insert the IUD during the menses. So pregnancy ruled out, mask insertion related bleeding, while cervical canal is more open. Which intervention is most likely to decrease the perforation at IUD insertion? So pelvic examination pre-insertion, ultrasound, sound the uterus, or insert during menses. So we have to do a pelvic examination prior to insertion just to see if you have a retroverted, anteverted uterus, what are you dealing with at the time of insertion. 4 ways to diminish the risk of perforation with insertion of the IUD, and it's listed down there. You have a patient who has an IUD, but the string are not visible. Name 2 tests prior to retrieval of the IUD, طبعاً beta HCG and an ultrasound. Management of a young woman with IUD in place and the string visible, but amenorrhea for 6 weeks. Name 2 things that you would do. So the same, beta HCG and an ultrasound. So now we're going to talk about plan B. في أي أسئلة إلى الآن؟ Okay, we will continue then. Plan B, طبعاً هنتكلم عن emergency contraceptions, indications, contraindications, mechanism of action, efficacy, and counseling and follow-up after emergency contraceptions. التايبس طبعا عندنا الهرمونال وعندنا الكبر IUD. So hormonal, they have to be used within the 5 days after intercourse happened. طيب الاوبشنز اللي عندنا levonorgestrel 1500 times 1, or you can use 750 every 12 hours, so times 2 doses. Okay, there's the use-B method, so you have to use 500 of levonorgestrel Q 12 hours times 2 doses. اليوز بي method at least طبعا قلنا ال 500 هذه موجودة either for overall they can use 2 tablets. No, wait. في overall they can use اللي هو 100 they have to use 2 tablets عشان هي فيها 100 of estradiol and 500 of the levonorgestrel, or 5 pills of Ellis اللي هي فيها نفس الامount اللي هو 100 of estradiol and 500 of levonorgestrel, or اللي هو المينيوفال فيها 120 and 500. وفي الصيدليات دحين صار عندهم plan B محطوطة البيلز اللي البيشنت should take. الكبر IUD لازم يكون الانتركورس within اللي هو 7 days. اوكي. البروبلم with اللي هو الليفونيجسترول اللي هو the first type انه it causes nausea and vomiting, so you have to give the patient antiemetics when you prescribe it to her. Okay. Emergency contraception, the indications طبعا unprotected intercourse within 5 days for hormonal and 7 days for copper. Mist طبعا تكلمنا عن المست combined والبروجسترون والديبو. فالاي سي اللي هي الامرجنسي contraception وهذه اللي هي الاوبشنز انه when to use them. طبعا الاو سي بيز لو كان more than 24 hours late start or more than 1 pill in the first week ولا more than 3 pills in the second or third week. لو ايش اسمه ده البروجسترون only لو more than 3 hours delay. وفي الديبو إذا كان عندها more than 17 more than 14 weeks. Failure of barrier or fertility awareness method طبعا you offer emergency contraception at any time of the menstrual cycle because of the infertile time cannot be determined with certainty. Okay. بس دائما الاي سي بيكون اذا كان within 5 days for hormonal or 7 days for اللي هو الكبر. Contraindication طبعا الابسوليوت contraindications بيكون ال pregnancy because it won't work. Allergy to any of the components, so especially for the copper. لو واحد عنده Wilson's disease or copper allergy, pre-existing pregnancy والusual copper IUD contraindications. Hormonal emergency contraception consideration because the duration of use is very brief and the usual contraindication to daily combined use don't apply. The mechanism of action طبعا it interferes with ovulation, follicular maturation and ovulation process. For the levonorgestrel only works before fertilization. Okay, other actions it could thicken اللي هو cervical mucus, so it affects sperm migration, corpus luteum sufficiency, endometrial receptivity. It affects fertilization and zygote development and transport and adhesions. So effectiveness, efficacy في typical use للlevonorgestrel it's about 85%. Use B 65%. Well, copper IUD is the best. It's about 90%. Pregnancy rate is low, the lowest with the copper. بعدين levonorgestrel method. بعدين use B. Side effects it's more with the use B 50% because it contains estrogen and progesterone in high doses, levonorgestrel وبعدين الcopper IUD. So best طبعا levonorgestrel less than 24 hours, 95% efficacy. From more than 24 hours to 48 hours بيكون 85%. ولو كان more than 48 hours بيكون 60% effective. اليوز بي لو كان less than 24 hours بيكون 80% effective. لو كان 25 to 48 hours بيكون 40% effective. لو كان more than 48 hours بيكون 30% effective. Weight for levonorgestrel ideally لو كانت the patient less than 75 kilos. It's not effective if she's more than 80 kilos. So if she's more than 80 kilos, she needs to use the USB technique or she needs to use copper IUD. So about counseling, so you have to explain and counsel them about the emesis within 2 hours, repeat dose PO or PV, offer STI prophylaxis, warn about the possible failure rate. If no period in 21 days, they should do a beta HCG, 28 days if OCP was started. If copper IUD emergency contraception is used and pregnant, remove the IUD immediately and rule out ectopic pregnancy. Past questions. So describe 2 regimes of emergency contraception. A woman presents on day 5 after unprotected intercourse and wishes emergency contraception. What is the best option? So emergency medical contraception, insert an IUD. Tell her there is nothing to do, so you can insert اللي هو ال IUD. Patient has had unprotected intercourse 4 days ago. She is on day 16 of her period of 28-day cycle. Call for emergency contraception. What is the next best treatment? So اللي هو ال IUD. So زي ما قلنا في السلايد اللي فاتت إنه there's no relation to the days of the cycle. طيب the timing of the cycle does not affect اللي هو the emergency contraception recommended. What affects it اللي هو when did intercourse happen. طبعا السبيشال تايم هذه اللي هي الاوفيوليشن postpartum, lactation amenorrhea and the contraindication. So it's very confusing time for contraception advice. Postpartum, so ovulation in the perineum, if not nursing, ovulation will resume after 7 weeks, or menses after 6 to 8 weeks. If nursing exclusively, then unlikely to ovulate before 10 weeks. Ovulation can occur without bleeding, menses 8 weeks or 18 months. Postpartum contraception, so we have the lactation amenorrhea, 98% effective if meet all 4 conditions. So إذا ما جاتها period أبداً while she's lactating, less than 6 months from delivery, exclusively breastfeeding, and breastfeeding every 4 hours during the day and every 6 hours during the night. Postpartum contraception, so if less than 1 month breastfeeding, you can use اللي هو combined Depo or progesterone only. If she's breastfeeding from 1 to 6 months, then you can use the progesterone or the Depo. Breastfeeding more than 6 months, you can use any of اللي هو الميثودز اللي محطوطة. Absolute contraindication for combined pills if less than 6 weeks postpartum and breastfeeding. Progesterone only with Depo indicated for women who want to breastfeed. So postpartum contraception طبعا تقدري تستخدمي اللي هو ال IUDs, or you have to put in mind اللي هو ال expulsion rate. 48 hours to 4 weeks postpartum is a relative contraindication. And sometimes you have to wait for 4 to 6 weeks. Sometimes you really don't want the patient to get pregnant, so you have to insert an IUD 4 weeks postpartum. Postpartum contraception, so 4 weeks postpartum, not breastfeeding. What is the most effective method for contraception? So اللي هي حط لك هي كلها Depo, Mirena. Don't answer with combined pills because it's an absolute contraindication. Postpartum contraception, when is the earliest resumption of ovulation? طبعا هنا جاوب 6 weeks لأنه هذا أعلى شيء. في ويليامز اللي هو ovulation doesn't resume before 10 weeks. Leftover contraception اللي هو some random stuff that we're going to talk about اللي هو barrier contraception. So we have the diaphragm. هذا جاء سؤال في سنة من السنين اللي هو how to insert instruction about using a diaphragm. So it's inserted less than 6 hours before sex with spermicide gel cream. Extra spermicidal is needed with each coitus. You can leave it in for 6 or 24 hours after the last coitus and need to be refitted after childbirth or pelvic surgery, or if somebody gained or lost more than 10 pounds. A cervical cap, similar to the diaphragm, there's no additional spermicidal needed for extra sex. The maximum duration بيكون 72 hours. A sponge is inserted less than 24 hours before sex, and it's left in for more than 6 hours after. Past question اللي هو give instruction on using the diaphragm for contraception. هذه الإجابة. Which is the most effective in reducing menstrual blood loss due to ovulatory menorrhagia? So اللي هو الميرينا IUCD has the highest amenorrhea rate, high rate of decreasing اللي هو الفلو. These are some OSCE questions on contraception. So Depo Provera, and then there's a patient encounter about also contraception and about Mirena IUD. So this is I'm done with the contraception lecture. So you guys have any questions? دانا سألت failure rate حق ايش؟
لا قصدي هو في السؤال الأول كان mortality rate مكتوب، فبس كنت بكتب إنه failure rate.
على ايش؟
في البداية كان مكتوب mortality rate حقت IUCD. بس كنت يعني.
اوكي. طيب بعدين في again doctor if PID على ايش؟ وإيش اللي متوفر في السعودية؟ Can you again doctor repeat the slide of IUD with PID؟ طيب. So IUD and PID اللي هو لو مريضة if a patient has an IUD in situ in place. طيب وطلع عندها مثلا لما سويتي لها pap smear or if you took a swab and she has chlamydia or gonorrhea, cervicitis, so you will leave the IUD in and treat the chlamydia and gonorrhea. If she has PID, then you have to treat her first with 2 doses of antibiotics and then you remove the IUD. فهذا السلايد حقت ال STI وال PID. My question was regarding emergency contraception is available in the market. So in some pharmacies, you're gonna, if the patient goes and asks for Plan B, they have it available as a package. طيب Plan B اللي هو levonorgestrel. 2 pills, she can take them at the same time, ولا take 750 and then after 12 hours she takes the second pill, or she can buy a copper IUD. So those are the 2 methods that are available in Saudi. أي سؤال تاني؟ If there is place to take culture and send it for culture. ما فهمت السؤال ده، إيش يعني؟ If there is an infection. أيوة طبعا. If the patient has discharge or she's coming with vaginal discharge or itching or any symptoms of vaginitis, yeah, you have to take a swab. That's how we are going to know that she has chlamydia or gonorrhea, or some of them will have BV, like whatever organism you need to treat.
دكتورة أعتقد عهود تقصد إنه نفس IUCD نبعته for culture.
IUCD إذا عندكم STI ما تبعتوا STI IUCD حيفضل جوا ما حتشيليه. طيب you're gonna treat اللي هو الكلاميديا والجونوريا وحتتركيه. إذا المريضة عندها PID you can send it just to see if there's any actinomycosis or not, and after you treat the patient. بس عادة في STI ما حتشيلي IUD حيفضل في مكانه.
تمام شكرا دكتور.